Hello and welcome to the Crisis Jam, episode 178. My name is Dr. Chuck Browning, and it's a pleasure to be a host again. I'm really excited about our agenda today. Our main speaker and presentation is going to be by Dr. Brian Sims on the acceptance of crisis services by marginalized populations. We also have some really fantastic opportunities to hear back from SAMHSA and NASHVID. We've got a really cool crisis talk from Stephanie Hepburn with Chris Appleton. We have a very impactful Live Lens experience piece, and following up in our agenda, one of my buddies is going to do a strong talk presentation, Vic Armstrong. So please look forward to jumping into an exciting jam. As always, just a little bit of housekeeping. On our 988 Crisis Jam Learning Community website, you can check this for updates, register for the jam if you're not registered, check on past content. Jess did a wonderful job presenting on crisis continuum MCT services and featured some of our leaders and some very cool information from Preston Looper and Matthew Goldman and others. So keep tuned to that and stay up to date with what's going on the Crisis Jam. We are now up to 400 unique speakers since 2020, and we would like to have more. So please let us know if you have an interest or if you recommend someone and would like to offer an idea for a presentation for our learning community related to our crisis systems and the work that we're doing. Now we're going to lean into a couple of articles. I'm going to bring up my friend and colleague, Aaron Foster, who goes by Arrow. Are you on, Arrow?
I am here.
Hello. If you'll introduce yourself and then tell us a little bit about this first article discussing what's going on with CMS related to peer support.
Awesome. Thank you, Chuck. And good morning to everyone. So I am the Vice President of Peer and Crisis Development and Training at RI at Recovery Innovations. And I've been asked to talk about a couple of documents that came out just recently from CMS and from SAMHSA. And so we're going to be discussing these documents and how they're pivotal for the field of peer support. The first is going to be frequently asked questions on Medicaid and CHIP coverage of peer support services. Big issue out there right now from the Centers for Medicaid and Medicaid Services. And the second is expanding peer support and supporting peer workforce in mental health. That's an issue brief from Substance Use and Mental Health Services, SAMHSA, as everyone knows. And both documents offer crucial insight and guidelines that can significantly impact peer support and peer support services and impact the specialists who deliver these services. So we're going to start with this one first, and this is the FAQ document, which provides clarification. So this isn't a directive, but it really is a good guiding document regarding Medicaid and CHIP coverage of peer support services. It emphasizes the importance of expanding peer support availability in many healthcare settings, including emergency rooms and inpatient facilities. And for peer specialists, this is really a highly valuable document because it really advocates for fair compensation, ensuring that payment rates support a living wage for the peer specialists that are delivering these services. And it's also vital for the sustainability and the professionalization of peer support roles. Moreover, the CMS paper, it also clarifies the supervision requirements, which allows for some flexibility for the states to define who qualifies as a competent mental health professional. And this sort of flexibility can lead to more inclusive and supportive supervision structures. It can enhance the effectiveness and satisfaction from the viewpoint of the peer support specialists. And so by outlining these steps that states must take to establish this coverage, it provides a clear framework for expanding those services and increasing access and utilization, which is really essential to the mission of peer support specialists working in the field. We want to move on to the next one. So this is SAMHSA. Thank you. This is the SAMHSA brief. It's called Expanding Peer Support and Supporting the Peer Workforce in Mental Health. Hope I didn't say that too fast. It provides a comprehensive overview of the benefits of peer support and the strategies for integrating peer support services across the behavioral health continuum. There are many places still struggling with how do I integrate peers in some of these new locations and some of these new services. So if we can go back to the next slide again.
And I think we were doing this briefly to answer someone in the chat that wanted to have the
Oh,
logo
okay.
so they could see the top right-hand corner.
Gotcha. Thank you. Okay.
Will that cover it, Jessica? Thank you.
This SAMHSA document highlights peer support as an evidence-based practice, which we all know, but it's really good to keep putting that in the forefront. And how that practice improves mental health outcomes and reduces healthcare costs. What I liked about it was it includes examples from Georgia, Michigan, New York, New Hampshire, Oregon, Pennsylvania, Texas, and Wisconsin. And it has those links in there to those states' directives and documents to explore how they are accomplishing some of these goals. So from the peer perspective, it's really particularly significant is that it promotes the standardized training, something has been really dear to my heart, and the certification process so it can allow for reciprocity across the nation. It ensures consistency, and quality in the service delivery. So, and the national standards introduced this in this document, which is a separate document, but there's a link in there to it, provide a clear pathway for the professional development, and that enhances, once again, the credibility and effectiveness of peer support roles. The SAMHSA brief also addresses the challenges faced by peer support specialists, such as stigma, low pay, limited career advancement opportunities. And so by offering these strategies, SAMHSA seeks to overcome these challenges. It advocates for better working conditions and support, which is really crucial for the retention and growth of the peer workforce. It also highlights some really good, like I said, exemplary state practices and offering models that other states can follow and expand on. So these documents are invaluable resources for the peer support community, but really good for anyone in behavioral health to read over if you were looking at integrating peer services across the spectrum. It provides critical guidelines. The issue brief offers a comprehensive framework for that integration to happen, and promoting standardized training and addressing the workforce challenges. So not only do they validate the role of peer supports, that essential role that we know must be a part of this crisis continuum of care, but it also provides practical strategies and guidelines to enhance the impact and effectiveness of peer support services. So as we continue to advance this, these resources, I think, will be very instrumental in shaping the supportive, effective, and professional environment for all peer support. So back to you, Chuck.
Hey, thank you, Era, for talking about some good pieces of information that are all of us good to see. They're linked in the chat now so that you can read them and go through them and save them, but really impactful pieces to help drive that important essential care practice of crisis systems throughout the whole continuum and move that forward. I'd highlight this article from NAMI's Reimagining Crisis Response has sent this out with a request to, we've got until I think Friday, June 20th. The writing's a little small for these old eyes. To urge the FCC to finalize this proposal. And that is, again, just a reminder, we covered it in Crisis Jam before, but the movement forward to switch from using your area code for a 988 call to guide what center you get connected to versus geo routing. So understand that geo routing helps connect the person's calling to the general area of where they are, but does not compromise personal or private information such as geolocation would. And so if you are led to do this, we'll have this link shared with us in the chat where you can, there's a template to work on, you can take it, personalize it, send it in, and help advocate for this. It's an important guide so that 988 callers know, get connected to the area that they're located closest to. Those folks are going to be the ones to know the local resources and things like that as well. So lots of important impact in participating in this as well. Which brings us to our hot seat. We have an audience hot seat today. We've got a topic that's going to, I think, does have a really interesting tie-in to what we're going to talk about from Dr. Brian Sims. And so the question is, the average wait time to be seen in a hospital emergency department is approximately 2.5 hours. 87% of patients wait long enough to be seen, but there was a time when hospitals determined who they would treat or not. And that 1986 report, Questionable Hospitals, a detailed look at patient dumping, was particularly influential in passing what law? So if you could participate in the poll, and we'll get some audience questions and see where we are with that. PPACA, Cobra, Heart, or EMTALA. What is the audience thinking? So it's hard to imagine there was a time where you go to the emergency department and they could just say, we're not going to be able to work with you today. But that was the case. So looking at the audience, we've got an even spread for the bottom three pretty much, but vast majority, 61% going with EMTALA. Does the audience have the right answer? Yes, big majority. Everyone focused in on that. And that is the case. Likewise, the original guidelines in 2020 set forth a stake in moving forward to say, in terms of when there's a safe place to go, that needs to be a place that says yes. And in a similar way to the medical emergency room, that we don't have areas when you go to get help that say, no, you're not able to be in there. So that ties a lot into the introduction to our speaker and some of the things that he's going to talk about, which is acceptance of crisis service by marginalized population. Because what we clearly know is that sometimes when you do create barriers to access, that oftentimes they impact marginalized populations even more. And I'm just really looking forward to hearing this topic from Dr. Brian Sims, who's our senior medical advisor from Nashville. I made the joke in our pre-show that Brian's done about everything on the Crisis Jam. Included, he added one last week when he just jumped in just right in the moment to cover for a sub when our host wasn't in. So you've got your whole bingo card, as David said, Brian, covered for the Crisis Jam. So without further ado, so good to introduce you and get to see you again as always.
Well, Chuck, thank you so much for that wonderful introduction. I am just so thrilled to be able to provide this topic today because it's been something that has been a passion for me in terms of working in the field that we've been working with in a long time. Before I get to anything else, I'll do a shout out to Tanasha that it is definitely Go Ravens. We're all on top of that. So thank you for that entry into the chat room. I want to talk a little bit today, first of all, in the form of a kind of a disclaimer. I am one of the senior medical advisors for NASHBID, but I do want you to know that the content of this particular presentation is more reflective of myself. And you'll see as we go through this that it is really more my own personal experiences, but I thought that it had a huge tie-in, particularly with the 988 services that we all are ready and willing and able to talk about. But I want to start off with just acknowledging that since the launch of 988 in July of 2022, I've seen some amazing efforts on the parts of states to inform as many as possible the existence and the purpose of 988. Now, while the efforts have been productive, there still remains whole communities that are unaware of 988's existence or have had misconceptions as to its purpose. Now, in looking further into it, there are lots of reasons that could take place, and they're too numerous to be able to discuss in this brief format. So I wanted to tease out one that I consider to be a very important factor, and that is to pay attention to cultural sensitivity, cultural responsiveness, the acknowledgement of cultural history as a reason why some may not be accessing. So looking ahead at what studies are available, the one thing that we do see is that there are very few studies that have been there. And these studies attempted to measure the reason for acceptance. And really, I've found only two. So if we go to the next slide, we see that one of the studies, which is the one I'm going to focus on, was a Pew study. And this Pew study was actually conducted through Ipsos Foundation that did the survey for Pew. And another study that did come up was a study that was sanctioned by NAMI. And it was actually done by Ipsos as well that found similar data. But in the Pew study, what they found was when they surveyed individuals, and in this case, they looked at 9,000 surveys being sent out and roughly about 5,000 coming back to them. And what they did do in the survey, the ultimate results turned out that only 13% of adults in that survey had even heard of 988 and as well knew its purpose. Now, this survey was sanctioned April of 2023, which at the time would have been about 9 months after the launch of 988. And what they did was they asked people whether they had heard of the new 988 services. So those who responded yes were asked when someone should use it. So what they found was that awareness of 988 was measured as answering yes to having heard of the service, as well as providing an answer for when to contact 988, besides saying I don't know or not sure. So although 18% in this survey said they had heard of 988, over a fourth of them, 26%, indicated that they didn't know or weren't sure when someone should contact them. So that translated to the 13% that you see listed here. Let's go to the next slide, please. Within this Pew study, what you see is a drill down of some of the demographic data, that in that 13%, what you also see here is that when you take a look at it as it pertains to looking at race and ethnicity, you find that marginalized communities, communities of color, tended to have lower rates of understanding 988 and its purpose. When you take a look at age, the older the individual, the less was understood about 988 and purpose. You took a look at education. The ones that were not as well educated as others also had lower numbers of understanding 988 and purpose. And you look at income, and it also correlated with lower incomes with lower numbers of understanding. Let's go to the next slide, please. Now, in this, what we wanted to do was taking a look at some of the factors that may be involved in this and how we can make a difference. Now, looking at the previous slide where we did the survey, one of the things that we needed to take a look at was that part of the effects in the Pew study also indicated that people had concerns about potential negative consequences of calling 988. So in that study, I needed to mention that 2 in 5 expressed concern that 988 might result in law enforcement being sent, being forced to go to the hospital, being charged for services that they couldn't afford to pay, or other people finding out that they've called. So one of the things that we really wanted to focus on are why those misconceptions may be there, and try to see if there's a lens of operation where we can go in and try to figure out how to more inform them of what is available. And one of the ways and the methodologies, and there are many that I've seen the states use, is insertion of cultural sensitivity and competency into our assessment standards. And I want to point out in the beginning, we'll talk about it a little bit later, but leadership has such a huge position in the presentation of cultural sensitivity, both from buy-in as well as delivery of service. Now, why is culture important? Culture is important because it plays a significant role in how and when people are going to seek care for behavioral health conditions, as it can influence their comfort with seeking care. It'll shape their understanding of behavioral health conditions, and it will define their expectations regarding interactions with service providers. So when we incorporate understanding and appreciation for aspects of various cultures through culturally responsive care, it allows providers to personalize care to the cultural and the linguistic beliefs of each individual. So culturally responsive care can play an integral role in decreasing disparities in behavioral health, because when the individuals then feel comfortable with their care, they're more likely to continue seeking treatment. So when we look at this as culturally competent providers, they also help individuals to feel less embarrassed and shamed when related to healthcare encounters. Next slide, please. So with that, as I said, I don't want to give you information that somewhat suggests that the methodology or these procedures that we go to next are an end-all, answer-all for everything. What I thought I would do is pull it more personal and look at it from one community's perspective. Now, for Tanasha and others who may be familiar with the state of Maryland, I just want to go back just a little bit to just let you know that I'm a native-born Annapolitan. I was born and raised in Annapolis, Maryland. I grew up in a small community called Eastport, which was in the peninsula in Annapolis. Beautiful area. Don't come there now because home prices have just gone skyrocket, so you can't afford to live there. But nevertheless, in the 1950s, and I am dating myself because in the 1950s, as I was growing up, I lived in Eastport, and Eastport at that time was 85% Black and 15% white. At that time in the 1950s also, employment in that area was predicated on three factions. You either worked for the United States Naval Academy, which was within walking distance of our place. You either worked at a place called Crownsville State Hospital, or you were a waterman. So when you look at all three of those aspects, you see that the economic issue was also subdued, but you're also living in a community where at that time, we are looking at having a place where you could not even be born in that city. We had to go outside of the city for our parents to give birth because the hospitals refused to allow it. There was a distinct segregation from within that premise where you had individuals. We had a third elementary school on 3rd Street that was only for Blacks, and a much larger one that had much more resources on 5th Street that was only for whites. So there were lots of changes. So mental health issues were tied around conceptualization. And it was all built on the premise that if you had no money, you had no insurance, you had no mental health. So the only place that you could look at was going to a place that was called Crownsville State Hospital. And it was embedded in us that this was a place you did not want to go to. This was where when you went there, it was a terrible place. And as people were given that information, it was often used to discipline us. That if you did something wrong, you're going to go to Crownsville, and that's where you're going to stay for the rest of your life. What has happened, and I'll show a little bit later on, is that there have been tremendous changes that has reframed the thinking of this community that is built on these cultural perspectives. Next slide, please. Now, in this, what had happened was a young lady by the name of Antonia Hilton, and she is an NBC correspondent, MSNBC correspondent, who at age 18, when she entered into Harvard University, took on an intense interest in the provision of mental health care for Blacks and Black communities. And she found out about Crownsville State Hospital and began to explore it. And after a 10-year exhaustive study on Crownsville, she wrote a book. And you see the book there called Madness, Race and Insanity in a Jim Crow Asylum. This text was released back in January of 2024. What it did was it highlighted and reminded our community of where we were, but it also highlighted what took place different. And one of those things was how our Department of Mental Health and Hygiene started to look at state hospitals and begin to insert individuals and be culturally sensitive and trauma informed. You really have to give credit to Dr. Hepburn, because at the time, Dr. Hepburn was the director of health and mental hygiene for the state of Maryland and envisioned putting us all in there to actually go in and start doing those kinds of things that opened up perspectives for people. In addition to that, Dr. Joan Gillese came into the system born out of living in the local area and began to insert trauma-informed perspectives. What that did in a short run was began to adjust our thinking and our acceptance and really made a huge difference in how we approach mental health issues. Next slide, please. So in looking at this particular piece, I want you to hear just this little portion from her.
What did your research uncover about the correlation between race and mental health?
Well, they're deeply embedded and entangled with each other. And for many Black families, the history of racism, of segregation, of struggle in this country is a major part of the development of depression, anxiety, substance abuse issues. And so what I argue in the book is that in order to solve these challenges, which not just Black Americans face, we all face, we have to go back and understand why was our system created this way in the first place? We can't come up with solutions. We can't imagine a better world until we better understand our current one. And one of the amazing things about doing this work, it can be heartbreaking. It can be hard to face these stories. But when you know your history, you feel a lot less alone because generation after generation, there have been people who have felt the same emotions that we have felt. They've gone through the same difficulties. And so as challenging as it was sometimes doing this work over the last 10 years, it also lifted me back up.
You know, I had a family member we had been told, a close family member, we had been told that, they died from something else and found out that they had been alive for a long time. It was in a mental institution and then died later. For you, there's a personal component to this.
That's right. So my family has a history of struggling with a number of mental challenges, from depression to anxiety to schizophrenia. And actually, for years while I've been writing this book, a living immediate family member of mine has been struggling with a mental health disorder. And that was really heartbreaking and dizzying at times, trying to save this loved one's life and working with all my siblings and my family members to support them and wrap our arms around them, while also writing about people who were going through these things 100 years ago.
And I put this particular clip in because when Antonia and I spoke about this, it was really to emphasize that in order to make a difference within communities, they needed to be aware not just of what had happened in the past, because they were all aware, but also what things make a difference moving forward. Next slide, please. Now, when we take a look at this cultural sensitivity, what I'm really saying to kind of close things out is that leadership needs to step up and continue to do the things that we're seeing happening in a lot of these venues, and that is to take that leadership role. And when you take that leadership role, you begin to implement cultural sensitivity training. You also measure those trainings. You take a look at diversity recruitment and mentorship programs, and as well, cross-cultural training and encourage open dialogue. Next slide, please. I'm going to fast forward pretty quickly because I just want to mention very quickly about the convening of a National Governors Association in Washington, D.C. And this took place about a month or so into the implementation of 988. And some of the amazing things that came out of that early a vision of where 988 was. I want to focus on the last one that says, well, first of all, just talk about cultural sensitivity training in healthcare providers can improve the satisfaction and health outcomes of patients from different minority groups. Now, because these standard measures, just as a reminder, involve diagnosis and prognosis, we need to remind ourselves that what we consider as providers as medical diagnosis and treatment strategies don't necessarily match a person's norms based on their culture. Let's go to the next slide, please. Now, this is just an example very quickly of some of the wonderful organizations and definitive connections that are being made as we speak in marginalized and communities of color. So it's not to suggest that it's broken, it is to suggest that it's moving in a wonderful direction. And we're just enhancing those things. Next slide, please. And I'm going to go ahead and jump to the last slide, but this is just a reminder that the inclusion of those with lived experience is just such a wonderful piece. So last slide, because I really want to kind of focus on this. By embracing cultural sensitivity, if we could go back to that slide, please. By embracing cultural sensitivity and fostering an inclusive environment, leadership and providers can create positive outcomes for the communities we serve. Now, in addition, in doing so, we actually garner trust as well as building hope. And we also build bridges that connect people across cultures and backgrounds, fostering understanding, respect, enhancing individuals' willingness to engage and remain in health services way beyond the call. So with that, I thank you all for your time and attention. And Chuck, I'll turn it back to you, sir.
Well, hang on and stay on too, Brian. We'll bring Wendy on as our panelist. Just thank you so much for that. But both personal impact of this discussion, it's so relevant. We need more of these on the Jam. I'm always such a fan of the ones that when we talk about this subject, because it's about care that feels like care for everyone. And, I go back to a long time ago, our discussion of using the history of 911 to help guide us in the development of 988. And 988 truly is the opportunity to transform all this way. And we need to continue to bring to bear the thoughts and the input and the impact of lived experience in that. So this talk was so helpful in pushing that forward, Brian. I appreciate it so much. Let me introduce Wendy Morris, also from Nashville, as our senior behavioral health advisor. Any thoughts, Wendy, on comments? And then we'll also be looking, if you have thoughts in the chat, please bring them on so we can discuss them.
Yeah, absolutely. And I agree. Such an important topic. And I have kind of a parallel story about my own early days in working in behavioral health and the healthcare industry. I moved at a young age, fresh out of college. I just finished nursing school and moved from upstate New York to the heart of Appalachia in eastern Kentucky, where I had some family history. I had visited and thought I knew a lot about where I was moving, but I was very young and very naive, and was quickly told that basically people, they didn't need anybody to come save them, that there was a long history of exploitation. And so it was difficult at first to make friends and make connections because of those influences. And so I actually overcompensated. I tried to really learn the dialect and learn the local colloquialisms. And then I was told, it feels like you're making fun of us. And so I really struggled for a number of months to really to learn that balance, right? To really engage in the community. And those are just really, they were hard lessons, but so important, those lessons, and the importance of cultural humility and sensitivity, and really understanding that culture history, things we didn't really talk about in the late 80s. And so glad to see that has shifted. But over time, I did find balance, and I was able to start working informally, kind of as a liaison for other people who are coming to the area, either for a few months or hoping to live. I can remember some physicians who really thought that some of the local religious practices, or just that a person would choose, in their mind, choose to live in deep poverty, was somehow a sign of mental illness. So. And that really served me well, too, when I went to the state level, just those important lessons. And the other thing I heard Brian say was making that kind of connection between the cultural humility and cultural sensitivity, and those principles of trauma-informed practices, so that trustworthiness, respect, empowerment, collaboration, humility, those are all so important when you're talking about trauma-informed practice, but also when you really are trying to engage any kind of marginalized community. You have to listen, you have to learn that history, you have to learn that culture, and be sensitive to the fact that you don't know it. You're there to listen, you're there to learn, and able to engage people. So that was just, great presentation by Brian, and such an important topic.
And Chuck, if I could just kind of interject, I knew that Wendy was going to talk about this, and I didn't have enough time in between, but I'm an old guy, so I share a lot of stories. I do want to give a kind of a parallel story, because it's something I think for medical providers. I told you I grew up in Eastport. I grew up in that community. I went on to become a doctor. I then come back to Baltimore, and I go to the University of Maryland, and I go through the Institute for Psychiatry and Human Behavior. And then through the wisdom of these guys, they allowed me to come back to Crownsville. But the person that came onto the campus was not the person who grew up in Eastport. Who came on the campus was a narcissistic psychiatrist who really thought that he was coming into an environment where people didn't know what they were doing. And I was going to teach them all of the proper ways of really giving out good care. I had completely abandoned my own cultural understanding. And what happened on an amazing day was the head nurse of one of the areas waited until I espoused all of my knowledge. And she came up to me afterwards and she said, Dr. Sims, it was something I just want to share with you that we all kind of feel. And she said, we don't like you. And it was followed by a statement that led up to 40 years of working. She said, Dr. Sims, wouldn't it be better if you watched to see how we operate before you pass judgment on what we need to do? And that was the lens of trauma-informed care. That was with the understanding that culture has such a huge piece in this, and that everybody brings to the table things that can make a huge difference in the delivery of care.
Brian, we need to save that quote, and it needs to come back as one of our quotes for Crisis Jam. It's an excellent one. and such an important lesson learned. And as Arrow shared first at the beginning, that along with many other tools, but peer support is one of those beautiful pieces of incorporating into care that helps add that level of insight and voice to things as well. So so appreciate you and Wendy being able to talk on this really important subject.
Yes, thank you.
Thanks, Brian. Bingo card is stamped again. And so now I'll go to David, who's going to give us our SAMHSA update. David, are you with us?
I am so sorry about that. Can you hear me? Good.
Yes, sir.
Okay, great. And I did have some slides. I don't know if folks were able to put those up. Okay, perfect. All right, so I wanted to talk to you all a little bit about the Certified Community Behavioral Health Clinic program, or CCBHC program, and some of the kind of latest things that are happening. I think there's a lot of exciting news. And I think most people are probably, have heard the word CCBHC or Certified Community Behavioral Health Clinic, but I wanted to provide a little bit of background for folks. So Certified Community Behavioral Health Clinics it's a relatively new program in the scope of things that was established under the Protecting Access to Medicare Act in 2014. And the first CCBHCs were launched in 2017. But it's a model of care that really brings together a comprehensive range of services in one place, incorporating evidence-based practices and other supports based on an assessment of community needs. It provides for improved access to mental health and substance use disorder services, to comprehensive mental health and substance use disorder services, including a lot of focus on how these clinics or provider organizations respond to people experiencing crises. CCBHCs are required to serve everybody who expresses a need for mental health or substance use disorder services, regardless of their ability to pay or place of residence across the lifespan. So anybody who has a need, who thinks they have a need, should be able to get served by a CCBHC. And really, if you want to understand what a CCBHC is, the most important thing to do is to look at a set of federally developed certification criteria. They're about 65 pages long. They lay out requirements for CCBHCs in a number of areas. And one of the things that I think is really important for this audience is that it's been a really happy accident of history that the 988 system has rolled out at the same time as the expansion of the Certified Community Behavioral Health System. And so if you can take one thing away from my presentation or talk today or update today, is that, it's great because, the 988 system is a place to call. And then from that, or for a place to reach out for help. And from that point, we now are developing systems and communities through CCBHCs that provide someone to respond, and then also provide a system for follow-up to make sure people are getting the help that they need, not only in that immediate crisis space, but in terms of community-based care in perpetuity through the time that a person needs supports in terms of outpatient behavioral health care. And so if you could jump to the next slide, that'd be great. So to understand what the certification criteria cover a little bit, first I'm going to talk about the fourth area you see on the right side, but I think the services are what people really care about. And so I want to talk a little bit about the service requirements for CCBHC. So all certified community behavioral health clinics, there's a little bit more than 500 of these across the country at this point, have to provide crisis services. I'm going to talk about that in a little bit more detail in a second. Screening, assessment, diagnosis, and risk assessment, person-centered, family-centered treatment planning, outpatient mental health and substance use disorder services. Again, this is across the lifespan, including psychopharmacology, including kind of the standard outpatient services you'd expect. Psychiatric rehabilitation services. This includes supported employment. This includes, other supports for social inclusion, assistance in finding and maintaining housing. Outpatient primary care screening and monitoring. So this isn't necessarily integrated primary care, although about half of CCBHCs offer that, even though it goes beyond what the model requires on site at the Certified Community Behavioral Health Clinic. But what CCBHCs have to do, the standard they have to meet, is to monitor, to identify and monitor common physical health conditions, and then to connect back to the primary and physical healthcare systems to make sure that they're getting addressed and to provide care coordination across those services. CCBHCs also have to provide peer, family support, and counselor services, as well as targeted case management, which means intensive support during periods where people really need more support. And that can include times around a crisis, or times when we know people are more at risk for suicide or crisis, such as exiting jail or prison, exiting an institution, or hospitalization. And then finally, CCBHCs have to provide community-based mental health care for veterans in a way that meets standards set out by the Veterans Health Administration. Beyond the requirement to provide these 9 very broad categories of services, CCBHCs have to provide staffing, have to be adequately staffed based on a local needs assessment and other requirements set out in the criteria. That includes training in a number of areas, including training around suicide prevention and responding in crisis. They have to meet standards around the availability and accessibility of services. And these are really important. So they have to, if someone has a crisis, a need for crisis services, they have to provide a mobile crisis response within 3 hours. If there's someone who has an urgent need that doesn't rise to the level of a crisis, they have to be seen the next business day. And for everybody else, they have to be seen in 10 business days. And they have to, again, see everybody regardless of their ability to pay or place of residence. So they can't turn someone away because of their insurance status. And they also can't turn someone away because they're homeless or because they're not a resident of the state. CCBHCs have to provide care coordination across those 9 services with a number of community partners. And then they also have to have health information technology in place in terms of electronic health records that meet Office of National Coordinator standards. They have to, as I've said, provide the 9 services that I just mentioned. They also have to engage in quality improvement and other quality reporting, including reporting on a set of quality measures, one of which measures time to crisis, or will after 2025, and time to receiving crisis services, but a number of other measures as well. And then all CCBHCs are required to do continuous quality improvement, including around critical incidents like crises. CCBHCs also have to meet standards for organizational authority and governance. So they have to have representation of the people they serve in governance, and they also have to meet, whatever their state requirements are for participation in Medicaid in terms of providing services. Next slide, please.
And David, we're going to have to pause and add on some more details to our presentation on the CCBHCs in a future. This looks like a really good longer term panel presentation for the future as well. But we're going to need to go break to Nashville. But thank you so much for sharing about that.
Oh, or maybe I'm breaking up. Oh.
Okay. So that brings us to Dr. Brian Hepburn from Nashville to give us an update from Nashville, please.
Thank you, Chuck. And I just wanted to reinforce what David was saying about the importance of the CCBHCs and the fact that SAMHSA has taken such a leadership role on this. I also wanted to bring up that yesterday, Margie Balfour and I were very fortunate. We were invited by the state of Illinois to present at their Behavioral Health Crisis Continuum. And it was put on by the University of Chicago and the state of Chicago and the Behavioral Health Crisis Hub, which is at the University of Chicago. So Margie and I gave the national perspective, and throughout the day, there were presentations on what's going on in Illinois. I bring it up as an example because all around the country, we have states that are focused on 988 and crisis services. And what Illinois is doing is a really good example under the leadership of David Albert, the Commissioner of Mental Health in Illinois. Others that participated that were very impressive, all of the individuals were very impressive. But Dr. Lori Jones, who was previously the commissioner in Illinois, Dr. Hairston, the Dean of Social Work at the University of Chicago. So I just wanted to highlight that example. Also wanted to go back to what Brian Sims was talking about, the importance of cultural sensitivity. I would add to what Brian said, in that Brian ended up being a very popular psychiatrist at Crownsville. He was highly regarded at Crownsville. And so I didn't want it to leave on a negative that people thought badly of Brian because he's a treasure and he was highly valued at Crownsville. So I also wanted to highlight the importance of geo-routing, and I hope people will weigh in and support the geo-routing. This is very important for the various reasons that have previously been indicated. The EMTALA issue was brought up. This is another important area that we think is necessary to address. I also wanted to bring up the fees that are being used to support 988 and crisis services. We're now up to, I think, Chuck, 9 states, Maryland being the most recent. We do know that 911 is supported by funding of about, I think, between $1 and $2 per month on phone bills per person. And right now we have for 988, we have it's between, I think, 12 cents and 60 cents. So what is the right amount? We're not sure, but the number of states are growing. We're seeing this movement going ahead. Fees are a really good way to find support or to get this, get the state and local jurisdictions too to provide support for the 988. So we're very fortunate, and congratulations to Maryland as the most recent state. With that, I'll pass it back to you, Chuck. Thank you.
Thanks, Brian. I think it's time to go to Sarah for our federal updates.
Thank you. Sorry, my Zoom took a minute here. If we can move to the next slide. Given that we've got a little bit over 6.5-ish months left in this current 118th Congress, I figured it might be helpful to go through quickly a little bit of the preliminary schedule for the next few months, as well as where we are in consideration for the next fiscal year appropriation cycle, which will be FY25. Quick note about these calendars: the yellow marks are for days that both chambers are in session. The blue is for only the Senate is in session, and this kind of peach color is only House is in session on these days. On the 27th of this month, we'll go back quickly. 27th of this month is the Labor HHS markup in the subcommittee on the House side for FY25. If we're looking into July, we'll see the full committee markup on the House side scheduled for mid-month. They also have the Republican National Convention scheduled for that month in the middle of the month. So we're also in the midst of an election year, as we all know. And we have been hearing that it will be sometime late July that the Senate will do their markup, but that has not been scheduled or announced yet. You can move to the next one. The reason why there's so much focus on getting things done in July and late June is, if you see, take a look at August here, pretty much the entire month will be in recess. So House and Senate members will be campaigning on the trail in the states, districts, etc. And then there's also the Democratic National Convention for the presidential election in August. September, they will come back, and on the 30th of the month is when the current fiscal year expires at midnight into October. So they've got a few weeks in session in September where they will likely pass a continuing resolution to keep the government open. Move to the next one. And then we'll see October, again, given the election year, not a whole lot of days in session there. And then November is the election, of course, on the 5th. And they've got a couple weeks in session before Thanksgiving recess, where we'll move into December on the next slide. So we've got 3 weeks pretty much in session, both chambers here in DC. And we did a quick tally as of tomorrow. There are 31 days that the House will be in session and 35 days that the Senate will be in session before the end of this current fiscal year. Before the end of the year altogether and the end of this current 118th Congress, we've got 51 days that the House will be in session and 59 that the Senate will be in session. And the new Congress will begin on January 3rd. So all of that to say, we've got not that much time, but a lot to get done before the end of this current Congress. And something to keep in mind in terms of the months that they'll be out, puts some extra pressure on the time that they will be back here working out next year fiscal year details and any other policies they want to wrap up before the end of the year. That's it for me.
Thanks, Sarah. Thanks so much. All right, now we're going to move on to one of my favorite sections, which is how it feels, and the first piece of that being the promise of 988 and our lived lens. So I'd love to introduce Alicia, who's coming up to us from Chestnut Health Systems as lead recovery specialist, and heard brief parts of your story, Alicia. I'm very excited about you sharing that with us here on the Crisis Jam.
Thank you so much, Chuck. I'm really thankful to be here. And I appreciate that introduction. It's very cool to hear everyone share this morning. Chestnut is actually part of the CCBHC, so that was very cool. So yeah, my story spans about 20 years. And within that course of time, as a person with lived experience, I had about, I would say 5 to 6 interactions in crisis situations. And boy, did I wish I had 988 then. So when I think about good care and the interactions I've had with law enforcement, EMS, emergency departments, what that looked like for me, both in, negative and positive ways, I think, really addressing things with all 988 staff, like stigma, JEDI training, so justice, equity, diversity, and inclusion, hiring more peer recovery staff, mental health first aid, things like that. I'm super excited about the geo routing because I know that at Chestnut, we have received many calls that were, location wise in the past, very far from us. So I'm very excited to hear about that. But I think, good care just really is empathy. It's relating to people on a very personal level, and treating them like we would our own families. That's so important. And I think about how 988 could have changed my life and my experience. And I really think that had I had these tools, I would have had a lot more years in recovery. Recovery is very non-linear, as we know, but I really think my story would have been successful a lot sooner had I had a resource like that. So I just want to say that, not only is recovery possible, it's very manageable. I'm super excited to see where 988 goes. When it first came out, I was one of the most excited people because I was like, this is a game changer. So I can only imagine how, like I said, how that would have changed my life. And I really appreciate all that we're doing across, the nation to make things better. But I really think, it really boils down to how we treat people. And I know the kindness and the love that I've been shown in the times where I needed it the most is really what has gotten to me to where I am today. So today I get to work in the recovery field. I get to go out and work with people without homes or people that need connections to services. And I could not be more thankful for that. So thank you for having me, Chuck. I really appreciate it.
Thanks, Alicia. I could not be more happy to have you share those words. And I love that quote about 988 had been there and that impact, because it really speaks a lot to what we're talking about today. Thank you, Alicia. I think next we've got our crisis talk article with Stephanie. Hey, friend, you ready?
Hi, Dr. Chuck. Yeah, so I'm going to bring on Chris Appleton. He's the founder and CEO of Art Pharmacy. And Chris, can you share how Art Pharmacy's arts-based social prescribing works?
Yes, thanks so much for having me, everybody. I'm Chris. I'm the CEO at Art Pharmacy. We enable healthcare providers to prescribe arts-based interventions to support individual mental health, social isolation, loneliness, and adherence to chronic disease treatment. The way that it works from a member journey standpoint is you go see your PCP or your behavioral health provider, FQHC, and they write a prescription. If you have a diagnosis or an indication around a behavioral health concern, they'd write a prescription for 12 doses of arts and culture, and call that prescription into Art Pharmacies, like they would call in a prescription for a traditional pharmaceutical to CVS or Walgreens. The member then connects with a care navigator at Art Pharmacy. We build a profile on them based on their clinical needs, social needs, access barriers, their demographics, and their experience and interest around the arts. Our technology then matches them to arts and culture activities in their community with protective and therapeutic benefits to their mental health and well-being. We then provide the member some choices to choose from for their first dose. They then select what they want to participate in. We always include access to companion access so that folks don't have to do these things alone. And then they go participate in that activity. We assess and monitor the patient throughout the entire journey. And they go participate and they come back to Art Pharmacy. That completes one dose cycle. That process essentially repeats itself once a month for the 12-month care plan.
Can you share also a little bit about your partnership with payers, how it's reimbursed, and if you don't mind just giving a quick snippet about what's happening at Stanford?
Sure. Folks ask me what we're really doing is called social prescribing, and people ask me all the time, how's social prescribing paid for? And the answer is all the ways that healthcare is paid for. So we have fee-for-service contracts, we have risk-based contracts. It really varies. We've been really focused on the Medicaid population and working with capitated provider groups. At Stanford students have access to Art Pharmacy as a student mental health benefit. So every student on campus can access it through a referral from one of our campus partners there that are what we call our prescribing partners. We're working with young folks. We're working with the older adult population, a range of folks, and just listening a little bit to the individual that shared their story before, just really made me think how important meeting people where they are is to addressing the challenges in the behavioral health field. And this is one way to connect with people where they are. From a time to care standpoint, we guarantee 72 hours time to care, which I think is really important, especially working with folks on government sponsored plans and the kind of supply demand challenges in the behavioral health space right now.
Thank you so much. And I'll pass it back to you, Chuck. I would just like to add in the article, we also chat about how this has helped people with taking their medication and with just treatment, being invested and engaged in their treatment, and that this is supplemental and part of the package.
That holistic care.
Yeah.
That's great. Thanks for sharing, Stephanie and Chris, for sharing this program. And that brings intro into my buddy, Vic Armstrong. We're going to get the strong talk intro music.
What's the word? Strong talk.
Vic, you're out there ready to talk to us?
Sorry, I had to take myself off mute. I'm ready. June is Men's Mental Health Month. One area that often goes ignored by men is mental health. In fact, data tells us that men are nearly 4 times more likely to die by suicide than women. This trend is proof that men need to start taking their mental health more seriously. There are a multitude of reasons and a multitude of stressors facing men that contribute to or exacerbate mental health challenges. Financial pressures, supporting a family, and juggling a career are just a few of the day-to-day challenges that can affect a man's mood. The additional stressor of keeping a facade of strength and not talking about these issues only makes the problem worse. There are also additional stressors that impact men of color, including the intersection of stigma regarding mental health challenges and the impact of health disparities and systemic racism. Lack of access to community mental health resources and treatment modalities that take into account the nuances of race and culture make it more likely that for men of color in particular, their introduction to the mental health system is far too often in the back of a police car or an acute care emergency room, neither of which is conducive to good clinical outcomes or fostering a positive relationship with the mental health system. While men and women both experience depression, women are in fact diagnosed with depression at a much higher rate than men. This is likely due in part to the willingness of women to acknowledge and talk about their feelings. Thus, their challenges may manifest very differently, while men are less likely to speak up about their mental health struggles and often internalize their pain. It is time to normalize men speaking up about their mental health and to create safe spaces where men can voice their feelings without judgment. These spaces break down the stigma surrounding men and their feelings and mean fewer men would suffer in silence. Talking about mental health puts men in a vulnerable position, which is understandably uncomfortable and often feels unnatural, particularly to a man who's been told all his life that sharing feelings indicates weakness, which is unbecoming. The key is teaching men to identify, understand, and respond to signs of mental health challenges and to recognize that there's no weakness in acknowledging a need for help. Acknowledging that you need help and asking for that help opens up a world of options, including therapy, medication, or some combination of both. The statistics surrounding men's mental health can no longer be ignored. Changing the way men engage with their emotions is a crucial first step in terms of turning around these numbers. Opening up about our feelings and seeking out effective care is essential if we as men are going to live our lives to the fullest. As men, we owe it not only to those we love, but also to ourselves, to be the best version of ourselves that we can be. There is no value or valor in suffering alone in silence. As men, it is time for us to be vocal, to be vulnerable, and to be visible as we create safe space for healing. And that is strong talk.
I like those 3 V's, Vic. Those sound really good. And thank you so much for that message. So we'll be getting ready to sign off now. And just to get a quick update, we will be no Crisis Jam on June 19th and June 26th due to observance of Juneteenth next week, and then the International Crisis Now Summit. So we'll be returning on July 3rd with a really important discussion. The Crisis Jam will be occurring in Amsterdam, June 29th and 30th. Thank you guys so much for your time today. Like I said, we'll have Sam Cochran and Michelle Saunders talking about CIT and giving a more in-depth piece of that piece of this, the way that people experience crisis and the importance and impact of that. Thanks so much for being here today. It was a pleasure hosting again, as always. And what an amazing group of people and presentations that we had. Thank you.